name is my name is Mahalia Robinson, and I am a second year pathology resident at Johns Hopkins. And today I am happy to serve as your moderator for this panel for exploring specialties in medicine. We have a dynamic panel for you guys today. And before we get started, I just wanted to announce that this part of the panel, so the panel session will be actually recorded, and the Q&A session at the end will actually not be recorded. So feel free to ask any questions you might have, as well as turn your camera on if you would like. And if you don't feel comfortable doing that, feel free to put your questions in the chat, and I'll be happy to read those. So without further ado, I'll have our panelists introduce themselves, and they're going to talk about their journey to medicine, and as well as their information about their respective specialties. Okay, I guess we can start with Dr. White.
Yeah, start with me.
Yes, you.
Good afternoon, everyone. It's so nice to see so many young individuals joining. It's really reassuring to see so many of y'all interested in going into the medicine and STEM careers. So welcome. So my name is Marissa White. I'm a surgical pathologist, and most of you probably have not heard of what a pathologist does. Those of you who might have heard what the pathologist does may think that we just do autopsies, which couldn't be further from the truth. Dr. Robinson is shaking her head because that's not what we do. So I'm going to share some slides to kind of introduce what we do, since our specialty is a little bit different than other medical specialties, but equally as important nonetheless. So let me, oh God, I messed this up already. Hold on. Share my screen. Okay, this one. Hold on. All right. Can y'all see slides? Success. Okay. All right. So exploring specialties in medicine, pathology. So a little bit about myself and my pathway into medicine. So I went to undergraduate at University of Richmond. I was a spider, ran track and field, went to Morehouse School of Medicine down in Atlanta, and then did my residency in anatomic and clinical pathology here up at Hopkins, followed by a surgical pathology fellowship, which I'll explain in a moment what exactly that is. And then I've been on faculty here since 2018 as an assistant professor, and I currently serve as our deputy director for diversity, equity, inclusion as well. So these are my co-residents up at the top of the dome in the Hopkins building, which is this little, or that little dome building there. And then these are my co-fellows. All right, so what do pathologists do? So we do a lot. We're physician consultants. We establish diagnoses and provide detailed information to guide patient management across all adult and pediatric specialties. So we touch every patient, even though we might not necessarily interact with them directly. So I'm not seeing patients in the clinic, and neither is Dr. Robinson. We're medical laboratory directors, so we ensure that medical laboratories function smoothly and efficiently to deliver patient care. So that means that if you get your blood drawn, if you have a urine test, if you have a pap test for cervical cancer screening, all those tests are run in a pathology lab that is directed by a pathology medical laboratory director. We're physician scientists, so we combine the understanding of diseases with a passion to change medicine through research. And then we're educators. So what is pathology? It's broken down broadly into anatomic and clinical pathology, with anatomic pathology consisting of these subspecialties that analyze cells, tissues, and organs to diagnose disease, whereas clinical pathology is the development and utilization of lab tests to diagnose and manage diseases. And I'll explain a little bit about what that means in a moment. So anatomic pathology, which is what I do, is mostly based at the microscope. So this is what our microscope room looks like here at Hopkins. There's a lot of us. They often that pathologist basement. We're not in the basement. We're on the second floor of the hospital, window in my office. And it's a very collaborative, collegial environment. So this is what it looks like when we get a tissue sample. So we actually get, this is a colon resection for colon cancer, for example. So if you have colon cancer or breast cancer, that'll be resected or excised by a surgeon, and then we will evaluate it grossly in terms of what it looks like in terms of appearance, and then we'll look at it microscopically under the microscope after slides are made. There are some other subspecialties within anatomic pathology. That includes cytopathology, which is the diagnosis based on just a few cells. So we'll take a needle and they'll aspirate through the needle cells, and then the cytopathologist will look at the cells under the microscope and say, hey, this is thyroid cancer, or this is melanoma, for example. And this is what it looks like. It's very difficult. I think it's analogous to reading tea leaves. It's very complex, very nuanced, but it's a really rewarding specialty because you get to guide patient management through minimally invasive procedures without having the patient undergo surgery. And there's autopsy, which most of you have probably heard of. So there are hospital-based autopsies, which determine the cause of death in non-suspicious hospital deaths. And then, of course, forensic pathology, where you do forensic autopsies to investigate the cause of death in suspicious or sudden unexplained deaths. For those of you that are in the DMV, the DC, Maryland, Virginia area, this is our medical examiner's office down in Baltimore. It's a state-of-the-art facility. They have on-site CT scanners. They do a lot of conversations with the medical legal death investigators to determine the circumstances under which the decedent passed away, and things that the autopsy or the forensic pathologist should be considering for the autopsy. So that's anatomic pathology briefly. Clinical pathology, on the other hand, is laboratory based. So this is our core lab down in the Zia Tower of Johns Hopkins Hospital. And you can see there are a lot of machines here, a lot of automation, a lot of instrumentation. So what our laboratory directors do is ensure that all of this instrumentation that performs the actual blood tests make sure that those instruments are performing properly, because you want to make sure that the results that the machines are providing are accurate. So there's a lot of technology that is utilized for these tests, and the clinical pathologists make sure that technology functions properly. Another specialty within clinical pathology is transfusion medicine. So they manage the blood bank. So if you get a blood transfusion, or if you have a complex transfusion need, like, for example, sickle cell patients or infants, transfusion medicine doctors will be available to consult for those cases and guide transfusions. Many of you with the COVID-19 pandemic are now more familiar with medical microbiology, and those are individuals in pathology who are experts in infectious diseases, who diagnose bacterial, fungal, viral, and parasitic infections, and they utilize lab techniques and newer molecular techniques to diagnose microbial infections. So, for example, these are two of our nationally, internationally known medical microbiologists, Dr. Heba Mustafa and Dr. Karen Carroll. This is a picture of them when they were developing our own Hopkins-based COVID-19 screening test. And so again, not only just diagnosing, but developing the tests and making sure that they function properly. So I do surgical pathology. So I don't do clinical pathology. I don't do any autopsies. I do surgical pathology. And most of what I do is diagnose cancer. So how is cancer diagnosed by pathologists? So first, what happens is there is some tissue that is sampled for cancer diagnosis, either through a biopsy. So Dr. Aguh is a dermatologist. She may do a punch biopsy of an atypical skin lesion, and I will look at it under the microscope. Alternatively, you may have something that's excised or resected, so a larger resection. This is what it looks like. It's either a small little biopsy here, you can barely see it, or a larger piece of tissue. The first thing that we do is we do what is called a gross examination, where we evaluate what it looks like macroscopically. We describe that this is a, pale tan, irregularly defined lesion that's involving the, pelviceal region of the kidney. And then we sample the lesion and put the tissue into these small little plastic boxes. And then from there, we have histology technicians who perform additional fixation of the tissue and embed the tissue fragments that were cut by the pathologist or pathologist assistant and put them into a block of wax, essentially candle wax, for lack of better words. And then they use a very fine blade and cut 5-micron thin sections and apply it to a glass slide. And then from there, we have tissue on a slide, and then we look at it under the microscope. This is our multi-headed microscope. So what do? We diagnose tissue on a biopsy. We'll establish, the type of cancer and subtype. We'll establish the grade. If it's a resection, we'll confirm the diagnosis, determine how advanced the cancer is, and determine margin status as well. Did the surgeon completely resect the cancer? And all the information is detailed by the pathologist and then reviewed by the surgeon, oncologist, or radiation oncologist to develop an individualized cancer treatment plan. So in a nutshell, that's what Dr. Robinson or maybe will do. I'm not sure if you're going to go into cytopathology, which it's really brave of you, but that's what I do. I like it because it provides a lot of flexibility in terms of work-life balance. I have a 7-year-old, so I'm able to go to school, during the day and, go supervise recess and lunch or read to the class and then come back to my work and look at my slides. So my schedule is much more flexible and have a better work-life balance. I think that fits my personality. It is intellectually challenging in that, we're expected to know a lot of information about a lot of different types of tumors, and we're expected to be the experts. Sometimes, we see cases that are exceedingly rare, and our clinical colleagues in other specialties may refer to us for information on, how things are supposed to be managed. And so it can be very intellectually challenging, but our days are very diverse. No two cancer cases are the same, even if it's 2 breast cancers. So it's very interesting and keeps you on your toes, for lack of better words. So in closing, that's all I have about pathology. My email address is here, and that's all I have.
Thank you so much, Dr. White, for shedding some light on our wonderful specialty of pathology. Next, we have Dr. Crystal Aguh in dermatology.
Thanks so much. I just wanted to let me share my screen with you guys. So, one second. Okay, great. So my name is Crystal Aguh. I am a dermatologist at Johns Hopkins, and I'll tell you a little bit about my journey. Really going to emphasize advice that I would give to you guys at your stage. I hope all of you go into medicine. In all of medicine, we really value the diversity of experiences, and our patients really value it as well. And when I talk about diversity, it's really important, especially in dermatology, because we see so many different skin types, and some diseases present very differently depending on your ethnic background. So a little bit about my journey. I'm from Texas originally. I was born to Nigerian immigrants. And when I was a kid, I wanted to be a doctor, but by the time I was in your shoes, I wasn't so sure. I actually majored in economics, but I did complete all of my prerequisites just to be on the safe side. So what is my best advice for you guys? Well, I think that it's very important to do well in college, whether or not you decide to go into medicine. College also gives you exposure to a variety of courses that you'll never see again. So you want to learn as much as possible. One of my favorite pieces of advice to provide is to travel on someone else's dime. So while you guys are in college, everyone values your learning experience. You can learn overseas as well. And it really just expands so much about what you learn of the world. Make lots of memories. I was very involved in a lot of organizations when I was in college. On the right there, this is my chapter of Alpha Kappa Alpha. This was at our homecoming this past fall, but I continue to keep in contact with so many members of my organization, including college students who are applying to medical school. And so when I was in college, one of my sorority sisters was a doctor, and she wrote me a glowing letter of recommendation and instilled so much confidence in me. And I really think that that was the reason I was able to do well in medical school, really just using her as a guiding light. And then finally, consider a gap year after college to prevent burnout. I worked as a consultant after I graduated from college. And when I entered medical school, I had so much more energy. Like, I worked as a consultant, and while it was not a bad experience, I could tell it wasn't for me. And so when I started medical school, I was like, wow, okay, I'm finally here. I'm so excited. I can't wait to learn. And some of my other friends who I think had gone straight through were kind of like, wow, like, I kind of need a little bit of a break. So depending on your personality, you may want to consider a gap year. So this was my study abroad experience in the bottom. This was many, many years ago. I studied abroad in Italy. You can see my graduation day here. And then I went to medical school. I went to the University of Pennsylvania, where I fell in love with dermatology, and then trained at Johns Hopkins with Dr. White. Dr. White definitely put our ages on the screen, but we trained together. We overlapped, because as I will show you, and as Dr. White mentioned, there's a lot of overlap between dermatology and pathology, so we ran across each other during training. While I was in medical school, though, I went abroad again, and I did a summer health internship in South Africa. I'm planting a kiss on my adopted sister. I lived with her family while I was in South Africa, and I worked in a hospital, mostly treating patients with HIV and tuberculosis, and it was a life-changing experience. So again, kind of using the opportunity of being a student, applying for grant funding through my institution, to kind of have this life-changing experience and widen my my perspective on things. And then I did this again in Austria, right before I graduated from medical school. So now I'm a board certified dermatologist. I focus on diseases of the hair and scalp. So as a dermatologist, we are the hair, skin, and nails experts of medicine. So anything that pops up in any of those three regions, that's our territory. I do a lot of different things, and I think that this is important to know, right? Because as a student, you've probably only interacted with doctors as a patient. And so you think, okay, well, the only thing a doctor does is, what I see them do, but we do so much more. And so I've worked at ABC News before. I have an interest in health, and health-related news and media. I've written books on various topics. I have a personal interest, in addition to hair loss, on reproductive health and cancer, especially forms of skin cancer that disproportionately impact people with pigmented skin types. And then I do a lot of research. So about 50% of my time I'm seeing patients, but about 50% of my time doing clinical research. Is actually half of my salary. And so it does allow for added flexibility, which I think is important. So these are some books that I've written about hair care and hair loss, just really emphasizing my interest in increasing public knowledge about different conditions that can affect patients. So what are the upsides of dermatology? Well, if you become a dermatologist, you are a fan favorite at every party, because guess what? Everyone has skin. And when they know you're a dermatologist, they want to ask you about their skin. They want to ask you, what's the best product for my face, for my hair? Do you think this is a skin cancer? My cousin has a rash. And so if you are an extrovert and you like to have a reason to strike up conversations with people, consider dermatology. We see so many different skin conditions every day. No 2 days are the same. And so that's really, really exciting. When it comes to interacting with our other specialties in medicine, we are, like, I call us the wizards of medicine. If there's a patient that's hospitalized and they're doing worse and worse and no one can figure out what's going on, a lot of times those teams will call dermatology and say, hey, can you see if there's anything on the skin that would explain why this patient is so sick? And we can. So much of what our bodies experience is visible through the skin. And so it's really, really cool and very interesting. And then finally, as a dermatologist, every day we're using a combination of medical, surgical, and pathology skills. And so as Dr. White mentioned, as a pathologist, they will look at things under the microscope and describe them. And to become board certified as a dermatologist, you have to be very competent in doing the same thing. So you have to be competent at identifying different cell types underneath the microscope. And nowadays, the way I use that skill is if Dr. White reviews a slide and she tells me in in lots and lots of detail what's going on under the slide, I can, envision what she's describing and I can interpret that for my patient. And so that's a very important part of what I do. Yesterday, I had surgical clinic. And so as a dermatologist, we see patients, but we also do skin surgeries. So this is an example of a surgical excision on the scalp. I did 2 of these yesterday, but you can see we cut things out, and when we stitch it back together, the goal is to make it look like nothing was there. Now, this patient, I think, may have a little bit of a recurrence of his cancer. That's why he has some of that buildup there, but typically scars heal quite well. So my pearls for medical students, I know you guys are mostly undergraduates, but what would be my pearls as you look into the future? Well, as you think about what you want to do, think about your passion, right? Turn your passion into your day-to-day job. What organ system just really excites you, right? That you love just talking about something. That's what you should do. I think it's also important to network a lot. Opportunities like this continue to exist even when you're in medical school. And just having people know your name can be really important, because you don't know who will think of your name when an opportunity arises. And then if you're unhappy, just adjust, right? I think for a lot of people, they feel like when they're in a position, whether they're in medical school and they realize it's not for them, or they're in residency and they realize they're in the wrong specialty, there's always an opportunity to pivot. So dermatology in the real world, if anyone's brave enough to unmute themselves and say who this is.
Winnie Harlow.
Yes, you said Winnie Harlow. Yes, this is Winnie Harlow, right? So think about dermatology. Unlike other forms of medicine, our diseases in our patients are visible to the average person. So, right? So if I had high blood pressure, you couldn't look at me and tell that I have high blood pressure. I'd have to tell you that, right? But when someone has a dermatologic illness or skin disease, people know. And for that reason, our patients are very, very, can be very bothered by their skin condition, though I think Winnie Harlow has been a great example of someone really embracing her skin and the skin she's in, but it can be very emotionally devastating for our patients, and our patients therefore are really highly motivated for treatment. And dermatologic care is really popular and well sought out, I think, for that reason. These are conditions that we see occur disproportionately in those with pigmented skin types. So albinism is when people are born with the inability to produce pigment. This does not occur more commonly in brown skin. It's just more noticeable in brown skin, because if someone's born and all of their siblings are really melanin rich and they're not, it's obvious. Whereas it can be very hard to pick up in someone of, say, Northern European descent, who maybe just looks really, really fair with blonde hair, but doesn't necessarily look that different than his or her relatives. So it occurs with equal frequency across ethnic groups. There are some populations in Africa, however, that do have higher likelihood of developing albinism, but you can really see this across the board. This may seem the same as albinism, but this is vitiligo. So this is what Winnie Harlow has. So instead of being born without the ability to produce pigment, you actually lose the ability to produce pigment over time. This is what's called an autoimmune process. And so again, this can occur in anyone, but if you are someone with naturally melanin-rich skin, it's just going to be more obvious. This is a perfect example of that. So this patient not only has vitiligo around her eyes, but she likely has some on her chest as well, but it's less disfiguring than it is for the girl on the right. Does anyone know who this is?
I know she's a congressman.
Yes.
Oh, House of Representatives.
Yep.
I can see it. Well, I'm looking at her face. I just can't remember.
Yeah,
her
Ayanna
name.
Pressley. So you're absolutely right. This is a congresswoman, and this is a condition called alopecia areata. So just like vitiligo that I mentioned is an autoimmune condition, this is an autoimmune form of hair loss. There are many different types of hair loss. Only this one is considered kind of an autoimmune process, but this can cause people to lose hair not only on their scalp, but all throughout their body. So many of our patients will lose their eyebrows, their eyelashes, all of their body hair, and this can also be quite disfiguring. These are razor bumps. The dermatologic term for this is pseudofolliculitis barbae. This happens most commonly in those with curly hair types. So we'll often see them in our African-American patients, but this can happen to anyone. Really, it's the curliness of the hair that dictates the likelihood of getting it from shaving. And then this is another form of autoimmune skin disease called discoid lupus. This is a type of scarring process that can occur. This occurs more commonly in those with pigmented skin types, particularly those of African and African American descent. And the disfigurement can be permanent. And so we like to treat these patients quickly. So that's it. I just want to give you guys a quick overview of some dermatologic conditions and what we do. And I'm looking forward to your questions during Q&A.
Thank you so much for that, Dr. Aguh. And last but not least, we have Dr. Candice Thompson in breast surgery.
Hello, everyone. So sorry I was late. I was rushing out of the OR. Let me just quickly share my screen. There it is. Okay, can you see my screen okay?
Yes, but it's not in presenter mode.
Right, I'm going there. Okay. Hi, everyone. I'm Candice Thompson. I am a breast surgeon, a breast surgical oncologist. Very excited to discuss my journey and my path to becoming a breast surgeon. I'm at Stanford University, and let's go through things. So I did my undergraduate at Howard University. I was actually there at the same time as Janelle. I was a chemistry and mathematics double major. I was involved in a lot of clubs and research opportunities. There was one that Janelle and I were in, Dr. Maynard, which was Howard Hughes Medical Institute, which provided great programs for us while we were in undergrad in order to be involved in multiple different research opportunities that we probably would not have otherwise. So highly encourage getting involved in those sort of opportunities early on. I'd stayed at Howard for medical school. I was also involved in multiple clubs there, and I did research while I was in medical school as well. Each summer, I would apply for a research program so that I could go to different places and do research over the summer. So that was always a great experience. I then did my general surgery training at Georgetown in Washington, D.C., which was an amazing experience. And I did surgical oncology fellowship here at Stanford. So as far as the routes to breast surgery, there are a few different routes. You can do general surgery residency, which typically is anywhere between 5 to 7 years. Some programs have like a built-in 2 years for research. And then I did breast surgical oncology fellowship, which is 1 year. You can also do an overall surgical oncology fellowship, which is 2 years, and that's where you're doing all types of surgical oncology. So anywhere from pancreatic cancer to thyroid cancer to breast cancer. So that one is 2 years. And if you want to focus just on breast alone, you can do a fellowship for 1 year. So why breast surgery? Well, for me, like I said, I was involved in research projects in undergrad and in med school. While I was in med school, I had a few mentors. One was a plastic surgeon and another was a breast surgeon. And I embarked on some research projects with them looking at disparities in treatments for African American women when it comes to breast reconstruction after having a cancer diagnosis. And from there, I really sort of fell in love with the specialty because it is a surgical subspecialty, but it does allow you freedom. And I'll go into the pros and cons later. It is something that impacts the community. Most people know someone who has had breast cancer. It's the second leading cause of death among women. And there is increasing rates of breast cancer in all groups except for non-Hispanic whites. 1 out of 8 women will get breast cancer in their lifetime. So like I said, someone knows, many of you probably know someone with breast cancer. So what exactly do we do? We remove benign and malignant masses, so things that are not cancer as well as things that are cancer. We can also perform oncoplastic reconstruction. And what that means is, like, if someone needs like a little lift while we're in there removing the cancer, we can also do that and make both breasts match each other. We do anything from something called a lumpectomy, which is where you just remove the mass itself, to a mastectomy, which is where you remove all of the breast tissue. And there are multiple different types of mastectomies. I won't go into all of that today, but we work very closely with our colleagues in plastic surgery as well for when more extensive reconstruction is needed. Some of the pros of breast surgery, as far as the surgical specialties are, is it allows you a lot of freedom with your lifestyle while also having a strong sense of accomplishment. Whenever you remove the breast cancer, it feels pretty good compared to like other surgeries where sometimes you may know that there will be complications from it. So minimal complications, minimal emergency surgeries. You get to make your own schedule. I didn't list this here, but you also get to work with medical oncology, radiation oncology, pathology, radiology. It allows you a lot of room for interdisciplinary work and research, which I also really like. We have weekly tumor boards where we discuss patients that are interesting with all of the different specialties so that we are all on the same page and you're always learning something. So I really like that about breast surgery. Some of the cons that people say, which I don't really think is a con, is you do have to do a general surgery residency, which can be vigorous. You work, there is a hour cap on how many hours per week you're supposed to work, which is 80 hours max. But you do have to work a lot. It is sort of, people think it's a long road. It's 6 to 10 years after medical school. So like I said, general surgery residency is 5 to 7 years, and then you have your fellowship afterwards. And then the other 2 are not cons. I think general surgery residency is what you make it. I made sure to have a good balance. I made sure to leave the country every single vacation that I have. You get like 3 weeks off a year. So I would go to different countries each year. And I think I traveled to like over 30 countries during my residency. So it is doable to have a good balance. You just have to figure out how to do that yourself. Some other things that I like to do as a breast surgeon is engage with the community. I currently have a grant with Stanford Cancer Institute, and I have partnerships with multiple different community partners. I am associated with Touch, the Black Breast Cancer Alliance, and involved with monthly webinars targeted at young Black women to discuss breast cancer and breast health. My actual grant is called the Alameda County Black Breast Health Seminars. And the ultimate goal for me was to educate our community when it comes to breast health and breast cancer. And just to help with relationships between patients and the medical field, because we all know there are barriers there, and create some sustainable outreach touch points. These are some pictures of my seminars that I host. And we also have breast models at the seminars for the participants to practice doing self breast exams, and it's connected to a computer system that tells them how accurate they are. And then being a breast surgeon, it's important to be visible within the community, be involved in conferences that are associated with your field, and that's for any field really. And then this is a picture of the breast models again. So yeah, I love what I do. I'm happy to talk more if anyone has questions about the specialty itself, or any questions about surgery or residency or fellowship. So thank you.
Thanks so much, Dr. Thompson, for that.